Welcome to the Benzo Free Podcast, your home for an honest, straightforward, and personal discussion about anti-anxiety drugs, their effects, and how to deal with dependence and withdrawal. Whether you have taken benzodiazepines, Z drugs, or any other tranquilizers, know someone who has, or you just want help dealing with chronic anxiety and insomnia, this is your podcast. I'm your host, D.E. Foster, author of the book, Benzo Free, The World of Anti-Anxiety Drugs and the Reality of Withdrawal. I'm so glad you joined us today. Please stick around and let me bend your ear for a few minutes. It just might feel a little better on the other side. Hello there, this is Dee, and welcome to episode 22 of the Benzo Free Podcast. Today is part 2 of our conversation with Dr. Stephen Wright. If you haven't listened to part 1, it might be a good idea to back up and listen to episode 21 first. Today's format will focus only on the interview. It's worth the extra time, trust me. But before we move on, do remember that the Benzo Free Podcast is for informational purposes only and should never be considered medical advice. That's it for our intro. Let's move on to our feature. In case you're curious about Dr. Wright's bio, we shared it last time in episode 21. Please check it out there. And that being said, let's pick up where we left off.
You know, one of my concerns is the use of other substances in the withdrawal process. Because there's, by definition...
That's a great topic to talk about.
By definition,
yeah.
You're going to have neuroactive substances there as well, which may be useful, but they may be problematic. And for those individuals...
And define that. What do you mean by the other substances?
Well, the other substances might be cannabis.
Okay.
Which very typically one might consider, I've got this calming kind of effect that occurs with cannabis. Why not use that? Well, one of the reasons is we may find 20 years from now, just like we found with benzodiazepines now, that there's a real adverse, more durable negative consequence than we had anticipated. What is a medicine? A medicine is a substance to solve a problem.
Right.
And whether that's derived in the laboratory or from a natural source, to me, doesn't matter. The real critical thing is, does it work? Right. Does it work without side effects? And if there are side effects, are they manageable? And will it have a durability of benefit and limited side effects over a long period of time? And that's where the real challenge comes in, because it's very expensive to do a study to figure out if something works or doesn't work.
How are these studies being funded?
Studies are funded in a couple different ways.
Right.
First of all, by pharmaceutical companies who perceive a potential economic gain by developing a product for which they have exclusive rights to and can sell over a period of time.
Okay.
There are a group of substances, however, that are generally recognized as safe, are considered to be supplements or nutritional products that are allowed to make claims on benefits through a 1994 law that are on the market already, and so pharmaceutical companies do not see the benefit of studying those particular agents.
Well, there would be no benefit. At most, it would actually be a negative benefit to their company if they uncovered
that it didn't work.
Exactly, or had complications and had severe long-term effects.
But that's true for the various vitamin products, et cetera, out there that are promoted. You're not going to see studies from those companies that produce supplements or vitamins because there's a potential that you'll identify that it doesn't work.
Right.
And in fact, vitamins have been shown to not work excepting in
and they also have kind of the loophole. They're outside the FDA's jurisdiction, aren't supplements and vitamins to some degree, so they don't have to go through...
To a certain degree, and that's the 1994 law that was promoted by Orrin Hatch way back in the day, which to a certain extent I take issue with because if that law were not in place, we would now have the data on substances that we don't have now. However, we have the NIH,
Okay.
National Institute of Health, NIMH, National Institutes of Mental Health, which does studies periodically on substances. So, for example, in the pain domain, glucosamine, we kind of had a sense that that worked for our puppies, right?
Right.
It appears to work well, but there were no studies. There was no economic gain for any company to really develop studies in that regard. Finally, the NIH did 2 studies and found that it works.
Yep.
And found that it limits the progression of knee arthritis on MRI studies. So eventually, the government agencies or not-for-profits will get to that. But we're not going to see that happen with benzodiazepines. There are a pair of study designs that I think are worthwhile. First of all is the typical efficacy study that can occur over a 12-week period of time. Now, because of the nature of benzodiazepines, I would suggest a longer-term study, a 24-week study to look at efficacy as a starting point. But then, and that's placebo-controlled.
But now that's efficacy. That's not looking at
side effects.
Side effects and complications and withdrawal.
So what you need with side effects and complications is 1 year, and because of the nature and the cost of it, you're going to have to do that with an open label process.
What about permanent? Later did some studies way back when on possible brain damage and, damage to those processes through these drugs. I mean, how, can these studies be done? Is that still something being looked into?
Well, yeah, it should be looked into, and we're looking into it in terms of what would be useful. What I think is particularly, these can be done.
Yeah.
It's just that it costs a lot of money to
Well,
be able
who's
to do
going to?
that.
I mean, I know governmental grants are very slim, and of course, as you mentioned, the pharmaceutical companies won't pay for these. Why would they? So where does that, like with your research that you mentioned the Alliance was doing, where does that funding come from then?
From all of you.
There we go. Thank
Well,
you.
it is indeed
Okay.
a real challenge because it's so very expensive to do efficacy study and 1 year safety studies or 2 year safety studies. What I think is the next best way to look at this to get to some answers is to look at the symptoms as they're expressed by the survivor community, the patterns. Why did you leave your medical provider? Because I think that the benzodiazepine survivor community is largely invisible to medical providers and researchers.
Okay.
And so I think to study that particular group, pair that with animal research that says, hey, these crazy sounding symptoms actually have valid neurophysiologic basis. You put those two together as a starting point, and then perhaps we can get changes at the regulatory level, which by that I mean we at the Alliance for Benzodiazepine Best Practices want to see a change in scheduling with the DEA.
Okay.
And labeling by the FDA.
And let's go back to that. This is scheduling, and I talked about this in the book, but you mind elaborating? What is the current schedule on benzodiazepines within the DEA?
All of the benzodiazepines are now at Schedule 4, which means that there is some addiction liability and some concern in such a way that they need to be controlled more so than a blood pressure medicine, which doesn't have that same kind of experience. Now, upscheduling to go to Schedule 3 or Schedule 2, you got to have rationale for that.
Okay.
The typical rationale for upscheduling is addiction. That doesn't occur
Exactly.
with much frequency in benzodiazepines. Some, which kind of places it at that Schedule 4. However, the language also says not only addiction liability, but also physiologic dependence.
Okay, there we go.
And so we at the Alliance want to sit in front of the FDA and make the case for the severity that is experienced in a subset of individuals to such an extent that it warrants greater caution on the part of prescribers, that warrants, therefore, upscheduling maybe to 3, maybe to 2, And so, for example, alprazolam that does seem to have
Yeah.
greater addiction liability might be a Schedule 2, and other benzodiazepines at Schedule 3. This
Okay.
would put prescribers on notice that, hey, there's a bigger problem out here than
Right.
previously recognized. Uh, but that's not the only thing we want to have happen. We want a black box that highlights particular concerns about withdrawal. We want an informed consent process that actually sits within the prescriber
Okay.
information is called the medication guide. If you look under medication guide within the prescriber information, which is the formally adopted approved, FDA approved
Mm-hmm.
information that prescribers receive about an agent. And then there's a thing called REMS,
Okay.
Risk Evaluation Mitigation Strategies. There was a law that was passed in 2008 that was enabling legislation for the FDA and actually required the FDA to provide additional education to prescribers when there's a higher risk for a particular medication. So, for example, we see that with the opioids today,
Okay.
that all of the companies that produce opioids, whether generic or brand name, must provide an educational module or mechanism for prescribers that prescribers can access and learn more about the safety concerns and how to manage all of that. We think that that's the way to go here with benzodiazepines, and one of the reason is that will have a multiplier effect because it's paid for by the pharmaceutical companies that are
Okay.
providing the medications. We don't have the money
Right.
to get the level of education out there that we need. But if the pharmaceutical companies have to chip in to
Right.
this process, then we think we may have something that'll have a stronger effect on the
Okay.
prescribing community. Because our ultimate goal at the Alliance is to change prescribing practices.
Exactly. Which is where it all starts. There's so many directions I want to go here. It opens up so many doors. But talking about the research now, from the layperson's point of view, like myself, there have been studies. There have been studies that actually, in our opinion, have shown that there is physiological changes and physiological dependence has been created by these drugs. I guess the question we have is, what does it take? What volume? What's the miracle study? How many studies have to be done? What's it going to take for it to be recognized by the DEA, by the AMA, by different organizations to say, hey, these cause physiological dependence. We need to change prescribing practices and develop, protocols for withdrawal.
It's not the presence of physiologic dependence in and of itself. It's
Okay.
the level of severity.
Okay.
And it's the issue of frequency. And so we would like to be able to identify how frequent it occurs, and there's uncertainty about all that. And certainly we
Fair.
have the information about the severity, but it's not in the literature. And so
Okay.
it really is going to take building the base of literature, speaking to that over time before we arrive with the FDA. I'm certain it's there. Your listeners here that are survivors know very well from personal experience it's real. We just need to make sure that it becomes evident in the literature now for all of us to see that. But here's the issue, evidence-based medicine. So the stuff that I think you might be referring to with Malcolm later are the imaging studies of the brain. But a picture of a brain that's abnormal doesn't mean there's a connection to a symptom.
Right, but there have been some studies, there's been some studies on, say, flumazenil, who actually have shown the relief of the symptomology by the infusion of the flumazenil. Now, correct me if I'm wrong, but
you have to connect neurophysiology to symptoms.
Okay.
We will have to connect the animal studies to what's happening symptomatically in human beings.
Okay.
You have to connect brain imaging to what happens symptom-wise. So, for example, we know in chronic pain that MRIs of the back, they can look horrible and you'd have zero pain.
Right, I got you.
So you have to make that connection occur. The same problem occurs in relation to trying to figure out what kind of a diet, what kind of health, general health things that you can do in the withdrawal process is going to make a difference.
Okay.
So keto diets or,
Right.
issues.
Well, there's so many things to research, especially on treatment of withdrawal and managing withdrawal.
But the problem is this, the evidence base that says neurophysiologically it makes a lot of sense. Things are better when you do, kind of a healthy diet.
Right.
That's entirely different than actually having a study saying, here are a bunch of benzo survivors who are doing withdrawal, and half of them did the diet and half of them didn't, and getting a result.
Understand. Okay.
That's a different kind of evidence-based process, and it's really important to understand that when you sit in our shoes as medical providers, we want to see the evidence that individuals that employed the diet got better and individuals that didn't employ the diet didn't get better, more so than just seeing that healthy diet is a good idea because of certain physiologic things. One of the things that a simple example that reminds me of why this can be problematic is the issue of bone density.
Okay.
It's kind of a diversion, I know.
Sure, go ahead.
So bone density has a lot to do with fractures. You
Right.
don't want to have fractures. As you get older, your bones tend to thin out. Fluoride makes your bone dense.
Okay.
Seems like it would work.
Seems logical, right?
Dense and brittle.
Oh.
And so just because physiologically you see dense bone doesn't mean symptomatically it translates into reduced fractures. That's why you need evidence-based studies on diet and other mechanisms to say this is the best way to go. Now, I'm all over a healthy diet, etc. I'm not going to discount any of that. But in terms of really having that seal the deal with medical people like me, you need to have those studies ultimately.
That makes sense. That helps. I think there's such the divide because majority of the people who have become organizers are lay people, are often the benzo survivors or caretakers of those people. And we're doing the best we can to catch up
Absolutely.
mentally and, to learn. I know so much more now about, I never even knew what GABA was before I went through this. And now I can recite details about GABA receptors, the mechanisms and everything.
Right.
We've been forced to train ourselves.
Exactly.
And we're just trying to get to be on par so we can have that evidence-based technical discussion with the providers and say, hey, this is what actually is happening. And we're looking for the clarity. And of course, like you just mentioned, there's so many mechanisms that might be involved. The clarity is lacking, and it may always be that case. But we kind of want to know, hey, it's this, this, and this. We're trying to get to that state because then our message will be clearer. And we believe more people will take us seriously. I think a lot of the work you're doing, a lot of the work the Alliance is doing and other teams and doing the research is helping build that evidence box. But I know a lot of people out there are thinking, these drugs came out in the early 60s. What does it take? When Senator Ted Kennedy came out in the 70s and said that these are, I'm paraphrasing, are disastrous drugs, referring to Valium and Librium at that time. And then for it to kind of just die off again, and now they're back again with a vengeance. Historically speaking, we're wondering what does it take for us to actually make the difference and change prescribing?
So we're in a culture, we're in a society where often it takes crisis.
Yeah.
It's just the reality of it.
Okay.
Doing addiction medicine and pain management over the years, used opioids and took people off opioids regularly when the whole issue came up with the fifth vital sign and opioids were the answer for all things. I didn't believe it for a second. But nonetheless, there were individuals that kind of tracked along that fashionable curve.
Right.
Just like we're in the fashionable curve now of removing opioids from individuals that probably do need it. I'm not going to say that there's nobody out there that would benefit from long-term use. But there certainly is a lot to be said for doing the tapering in a proper, very slow fashion.
Right.
and it's slower than I ever imagined it. And my
Yeah.
comments now, and it's not quite evidence-based, but it has to do with the presence of the severity of withdrawal that some individuals have, is that one should consider a tapering process when you start out to be about 18 months. And then if it can go faster than that, you'll see that by listening to the patient. The patient will say, "Hey, that last step, that was a breeze."
Well, and allowing the patient to have some say and control over their taper, because they can kind of sense when they want to stabilize at a level before continuing.
Well, that's absolutely correct. And this is where personalized medicine takes over from evidence-based medicine. So evidence-based medicine says go slow,
Mm-hmm.
but personalized medicine says how slow.
Yeah.
And it's a conversation. It's a back and forth. It's like that worked, that didn't, and how do we need to adjust with that? But it needs to be slower than one might anticipate for a couple reasons.
Okay.
First of all, it needs to be slow for a significant proportion of individuals. Second is individuals, and correct me if I'm wrong, that come in for a benzodiazepine taper are fearful. I, as a medical provider, going to throw you under the bus.
Yeah.
I am going to go, okay, let's do 10% per week until we're done, or something crazy. And so you need to have a therapeutic alliance that involves trust. And so as a medical provider, I recommend that prescribers do a couple things. First of all, I think it's useful to go to a long-acting benzodiazepine like diazepam,
Right. Yeah.
and then make the reduction less than 5%, 1 milligram,
Yeah.
for example.
And that makes it so much simpler for those who don't follow, because of course diazepam, basically like I was on clonazepam, which is 20 times the potency of Valium. So it's very difficult. I taper directly off of clonazepam.
Right.
I realized I took 16 months. My mistake was that last quarter milligram, which is as small as my cutter would cut my pill. I was dropping 5 milligrams, 10 milligrams of Valium at the very end.
Right.
Now I realize why I had problems.
Well, yeah, and no wonder. And so you go to, say, 40 milligrams of Valium, whatever the equivalent is, just to pull an example out, drop 1 milligram. What does that do? Well, you'll find out, is that fast enough? Is it too fast? And you also have a patient as a prescriber who says, hey, this person is not going to just run me over with this withdrawal process. I can trust this person, because you need to have trust in this process. And if that 1 milligram is a breeze, you can think of 2 milligrams next time.
Well, and like it was like with Clonopin and Halcyon, I believe it's a 20-1. With Ativan, I think it's a 10-1. People say 1 milligram. A lot of times, people don't know to ask, what drug are you on?
Well, that's correct. Yeah, because you can't just drop
No.
1 milligram of Clonopin and get away with it.
No, would not be. People have done that in cold turkey, and that didn't go well.
No. That's not a good idea whatsoever. But it's the back and forth. So evidence-based medicine just gets us down the road a little bit. Personalized medicine then is the real answer for how this goes going forward. Another reason why you don't want to go really fast, because if you go really fast, there'll be a moment where you say, oh, I got to go back up on dose or use as-needed medicines, and then you get into the kindling, where you fire up the central nervous systems in ways that make the subsequent reductions more difficult.
Can you talk a little more on kindling? Is kindling a physiological process that's been identified, or is it still more of the syndrome, or more of a, where does that lie?
Well, I think it's real, and it's just I'm not a neurophysiologist, but from what I have read, that the best evidence on kindling has to do with alcohol.
Okay.
And what the idea is that repetitive withdrawal attempts fire up neuroadaptations in such a way that subsequent withdrawal attempts are more difficult. And we've seen the same kind of pattern with regards to benzodiazepines. And so when you go on and off an agent, and that can be a relative thing, where you make a reduction and then go back up on the dose or use as needed medications, that there are adaptations that occur that make the subsequent reductions more difficult.
Right.
And I think that's the best model of describing what goes on for some individuals. I mean, in terms of the symptom progression, we certainly see that kind of a pattern out there. As to whether or not, the term kindling is the exact answer to that, I don't know.
Okay.
But it's the best answer that I come up with to represent that experience.
Okay. Let's go back to prescribing practices for benzos again. You had mentioned for, of course, alcohol detox and for medical procedures. We had talked a little bit the other day about also using them as a bridge drug. And is that still something you recommend? And if so, could you explain that a little bit?
Yeah, and that's what I mean when we talk about limiting duration of use.
Okay.
So benzodiazepines very effective in the short term for anxiety and insomnia related issues, and certainly can be recommended. However, just like with opioids, it has to do with using these agents that can be dangerous only when individuals are functionally quite impaired by their condition. So,
Okay.
I can't negotiate and get to work or take care of my kids because of my anxiety or my sleep problem or something like that. I'm just so overwhelmed. So there are other things that also work. And the problem is that benzodiazepines work right now and other
Right.
things take a while to start. They take a while to start, and it may take me a while to get to a therapist to actually start it.
So you're talking about therapy like CBT and that type of thing?
CBT,
Okay.
cognitive behavioral therapy, but even pregabalin. Pregabalin is
Okay.
probably the one medication that works the quickest, takes about a week. So if somebody is functionally impaired and the anxiety is significant, that causes the functional impairment, then the bridging with benzodiazepines while I'm getting something else going to provide the long-term solution is probably the way to go.
How do we keep that? So say how long is that prescription for? Is it for a week or 2 weeks? And if dependence can develop in 2 to 4 weeks, or even some people have said as short time as 11 days or something, how do we make sure that that person does not become long-term dependent?
We can't.
Okay.
I mean, we live in an imperfect world
Right.
in that regard. Historically, benzodiazepines were a great advance over the
Barbiturates,
barbiturates.
yeah.
So we're looking for another great advance. It just doesn't seem pretty evident on the horizon. Could be CBD, by the way, in terms of anxiety, but I don't know
Okay.
that.
Right.
I'm not advocating everybody jump out on that one.
And you're talking about, so when you say CBD, you're talking about hemp-based or straight CBD with no or little no THC, right?
Yeah,
Just
we
the
don't know
straight.
the exact answer
Okay.
to that because there might be an entourage effect that requires a little bit of THC. And actually, the entourage effect from THC is probably not as important as the entourage effect from the terpenes.
Yeah,
I mean, fundamentally, we don't know the answer.
exactly.
So and it's going to be a long time coming. And I want to make clear, too, that any of the discussion that I have is not a direct recommendation at all. You need to speak with a medical provider
Yes.
that has some basic knowledge about all of this. But again, you need to speak with a medical provider who's going to listen to you as well. It's a bi-directional, working through process.
Okay.
You're going to learn. He or she is also going to learn.
Yeah. So back to the topic, which was if somebody is extremely disabled and, like you said, can't get to work, then you start to consider the use of the benzodiazepine as a bridge drug.
Well, you don't take a lot of time considering it because this
Okay.
individual is in crisis.
Okay.
And we need to do something right now, but you need to not do just one thing, benzos. You need to get the other thing going too. But this is what I would do. I would, for somebody severely affected with an anxiety state, I would order the benzodiazepines and follow up in 1 week, 2 week.
Okay.
Order the pregabalin and make the referral. So in any one community, it may be difficult to get in a month,
Yeah.
but the pregabalin's on board. they're not functionally impaired, hey, I've got time.
Okay.
I'll get you to a therapist. And with a CBT kind of process going on, if that doesn't work, then pull in pregabalin.
Pregabalin is something I know little about. Can you explain what class of drug is it, and what effect does it have?
So pregabalin, the brand name is Lyrica.
Okay.
It's a calcium channel modulator, so it works outside to some degree, but does have a indirect effect on GABA. So there's problems.
Well, that's where I was going to go with this. Is how do we know there won't be long-term complications from the pregabalin?
We don't.
Thank you.
But here's the deal. Here's the
Okay.
deal. We don't live in a perfectly safe world.
Correct.
You know, coming up here to do this podcast, I could have gotten in a horrible accident. Am I going to stay at home all the time
Right.
to try to eliminate any risk? No, we're gonna do things that have some risk. We want to kind of keep things in a safe harbor. So
Okay.
chemotherapy for cancer. Is it really great? Yes, but there are some people that are going to die from the chemotherapy. So
Right.
with the medication, so it is not going to be perfect. Although what we want to do is improve over a period of time our ability to identify individuals who can be successful with benzodiazepines for the short term, or won't be successful on that 11-day trial that results in permanent problems. Eventually, I think we'll have better ability to deal with identifying those individuals as well.
Okay.
But it's an imperfect world. But you do want your provider to kind of be tuned in to some
Exactly.
degree. You don't want them totally. So back to, how do you relate to a medical provider? I think rather than giving declarative, definitive statements to people in any kind of relationship, the best strategy is to ask a well-constructed question. It does a couple things. It basically indicates a willingness to listen to the other person. You're not just in
Right.
there telling the medical provider
Good.
they're stupid, and you ought to follow, Heather Ashton to the word. Although that might not be a bad idea.
Fair enough.
But nonetheless, it's not a matter of. I realize that as a medical provider, the key element in the process of working with patients is not that I'm right. That's not the goal of the office visit. It's that somebody gets better. So it's not that the goal of the office visit for the affected individual is not to prove that you're right, but to have a solution you come together jointly that works for you. And so very typically it's better to ask a question that is kind of directed towards something you may even be aware of in terms of
Give me
a
an
side
example.
effect. Oh, boy. What should I do when in my withdrawal experience I have these loud sounds?
Okay.
Rather than saying, don't you know, medical provider, that
Gotcha.
the benzodiazepines and the withdrawal experience is creating this? But you ask a question rather than, the relationship goes both ways. What I found is that the three most important words in a relationship, regardless of what they is, it's not I love you.
Right.
Maybe you're right.
I love that. That's great.
But it's true for both sides of this equation.
Yeah.
It's true for the medical provider, and you want to hear that from your medical provider, that there's, okay.
Well, it kind of comes back to a little bit of Dale Carnegie's advice,
Yeah.
which questions, don't go in there and start lecturing, because nobody is responsive to somebody coming in and say, I know absolutely what's right, let me tell you.
Yeah. Yeah, so there's this new process out there, what's not that new actually, motivational interviewing. And what's the key elements there? Well, you listen empathetically, but the key thing is for medical providers, you ask patients, what's your goal in life?
Okay.
Separate set of questions. What's your current behavior? And are the two linked together? So individuals, so in the addiction arena, my goal in life is, to see my grandchild graduate from high school. What's your current behavior? Well, I'm smoking and I'm sitting here on oxygen.
Yeah.
Are those two connected together? 5 years from now, you're going to be able to show up to the graduation ceremony.
Odds aren't looking good.
Yeah, but I don't have to lecture to somebody to answer
I
that
understand.
question.
Yeah.
The set of questions, the patient then says, "Oh, that may not connect. And now, can you help me?" And the same thing as you're working with your medical provider, asking questions that are somewhat leading. That's true, but
But your approach is different.
your approach is different, and it actually is true. You don't necessarily know the correct
Right.
answer either, and so you're kind of coming to this uh, the answers together with your medical provider. Both of you have expertise. Both of you
Exactly.
have limited expertise in the other person's area.
That was the big realization I think I came through, and I moved from just listening to the doctor and trusting everything the doctor said to becoming a partner
Yeah.
with the doctor, saying, I know some things about myself. I know some things of what I feel. I know this better than you do. We're going to figure out how to get me through this. And I would I would like to withdraw. Can you help me?
That's exactly right. What I think is going to happen here is that in the field of addiction, in the field of benzodiazepine survivor community and the solutions that are attached to that, is that these groups are going to inform general medical practice as to how to do
Okay.
medicine properly. And the medicine properly is that there's a participation on both sides of this, and actually there is no side.
Yeah.
It's working together. So I was in a treatment center working in the 1990s, and I came to the realization that the physician was not the center of the medical universe. I was devastated.
I thought that's the way it's supposed to be.
I'm still working on that.
I know. Let me know how you're doing on that one. I'm curious
But it
here,
was true.
Steve.
But I came to the realization it was the care manager. Because what was happening at that particular time is that patients would move from hospital to outpatient and so forth, and my excellent plan could not be deployed because there was no care management to get them to the right setting without reusing
Okay.
their substance of addiction. It really is true. This is a real team-based process. It's real integration, and the integration needs to occur with the prescriber,
Yeah.
the pharmacist, the peer coach, the patient,
Mm-hmm.
the family,
Okay.
all of those together. And each individual or groups of individuals has expertise that the others don't have, and that's got to be respected and honored. And in your interview process of medical providers, individuals that you interview need to have the appropriate level of humility to recognize my role is this, and it's also my role is to listen to the expert on the symptoms that are occurring for this particular individuals and the
Right.
relationship between events, the waves and the windows kind of thing. Is there a
Yep.
connection between external circumstances and waves and windows that is relevant to the next iterative solution?
Okay. Let's close out with that one last topic, and we kind of touched on this at different times, but I kind of wanted to just tackle it as a center point, and that is what can we do? And you mentioned, of course, research is key. The Alliance is working on some of that. Of course, within the benzo community, lay people like myself are working on raising awareness. We're trying to get the message out and supporting those people who are withdrawing. I was on a team that was helping try to seek some changes within our government and include legislation. And I mentioned to you that we were working on informed consent legislation. You had some concerns about that, and I was wondering if you'd like to share with me your views on, especially from the legal aspect or from the governmental aspect, why that might not be or might be the best route and what other routes might be more effective.
Well, I'm a real advocate for going through the open doors,
Okay.
and that simply is not one.
And
And
why is it not an open door?
because there are many, many medications out there, probably 4,000 to 6,000 medications,
Okay.
majority of which have severe, although rare, side effects. What's going to happen is the perception of a slippery slope
Mm-hmm.
by the medical community. Are we going to have paper signed informed consent on each one of these
Okay.
products out there? It's impractical. We can't get the job done. There's not enough room in an exam room to keep all that volume of material or keep everything loaded into Word documents on my iPad or something like that. So there's just no way that the medical community is any parts of it. And I'm a benzo reformist, and I
Right.
don't think this is a good idea. So if I don't, you can be sure that the individuals that are not benzo sophisticated are all not going to be, because we're going to end up having to do this with diabetic medications and hypertensive medications and so forth, and it's just an impractical thing.
Okay.
So we want to make sure that something works. Second is, if something is going to be placed into a legislative area, we want to know that making it a legislative requirement actually does work. So in the informed consent process, just because you legislate it doesn't mean that I, as a medical provider, are going to do that.
Okay.
But third is, we actually have a process that's available right now that really requires that medical providers provide informed consent. And it's tied into my license. I have to practice at a minimal standard.
Okay.
And the minimal standard means that whatever treatment process that I recommend or provide to a patient needs to be attached to informed consent. So there is a process if I am deficient in that regard. And then, of course, two
But
medical.
if those physicians don't believe that benzodiazepines are a dependence-inducing medication, then they're not in violation of that ethical dilemma. Is that correct? Or
Well, no, I mean, not exactly. I mean, they have to have a sufficient knowledge base to know that
okay.
there are risks. And so, I mean, the potential is there is if you see an egregious example of a medical provider never doing informed consent, you can notify the board, and the board does an investigation. And I'm involved with the board on both sides of that issue, on behalf of the board, on behalf of physicians
But
facing the board.
would the board really, I mean, since benzodiazepine physiological dependence still doesn't seem to be the belief that that's a serious issue still doesn't seem to be pervasive in the medical community. Is that something the board will take seriously?
I don't know. I
Okay.
can't speak for the board, but I mean, basically, informed consent is not just an issue of, physiologic dependence on
Right.
benzodiazepines. It's, informed consent needs to take place on when I do stitching of a very simple laceration. And so that too doesn't have typically severe consequences most of the time,
Right.
but occasionally does. But I still, informed consent is still required.
So outside informed consent, where do we make the difference? One of the things that when we met with the Department of Health, we mentioned informed consent, and I kind of kept pursuing it as a team member, even after our conversation. By pursuing it, we were raising awareness of the benzodiazepine issue. One of the things that kept coming up in that conversation, and we've talked about this, was continuing education for the physician. Is that an arena that we can make an inroads? Is that an arena we can help to get benzodiazepines on the, what's the term I'm looking for, on the syllabus for that type of thing? Is that an area we can make a difference?
Maybe.
Okay.
Yeah, but the real question is how effective is your typical CME talk?
That is a good question. Yeah.
So, for example, you think, oh, guidelines, docs are going to follow the guidelines. So I believe, if I recall correctly, guidelines on diabetes in terms of establishing what ought to be done. About 6 years passed before 50% of providers actually started doing that, those guideline-related things. So I think, since we're a society that responds to crisis more than anything else, is that to go through the opportunities as they present themselves in crisis. Now, so for example, Matson et al., in an article, these are CDC folks, looking at opioid-associated overdoses, identified, it's not in the abstract, interestingly enough, but even though it's a big number, 51.6% of opioid-associated deaths also had benzodiazepines on board.
It's a big number, yeah.
That's a big number. That's a big number that should have been in the abstract, not just in the body of the paper.
Okay.
But it's there. And Dasgupta et al. In North Carolina found 80% of the opioid-associated overdoses. these are big numbers. These are of crisis proportions and need to be deployed in terms of how we describe that. Not that I want to support a society that only responds to crises, because had we been paying attention to the benzo issues outside of the crisis proportions that we're in right now, we'd be much better off. Nonetheless, that's how we operate.
And the little press that benzodiazepines seems to receive is usually focused on the overdose epidemic.
Yeah, so that's the
which makes sense.
That's the entree.
And it makes sense, but it's also frustrating for those people who have suffered the iatrogenic illness of being prescribed the drug and are dealing with the long term. Is our message still getting heard that this is a long-term dependence issue also?
Well, I take this as an entree. So somebody says, come talk to us about opioids, and you're talking about benzos now too. And so I actually very typically...
So we can use the opioid crisis to actually help us as a vehicle. I like that.
It's a vehicle in that regard. But the other thing is that, and I know there's initial work being done on this through Benzodiazepine Information Coalition, and that is because it's so expensive to do the studies to look at the side effects of the proportion of individuals at that severe level. Let's just go to the benzodiazepine survivor community and ask them questions. What are the side effects that you experience? How severe? What are the withdrawal experiences? How severe? What is your experience with continuing with the medical provider that you were with or no longer with? And why is that? So the Alliance, we just had our board meeting. We're going to support that process. We're going to ask that particular group, how can we support that? And there'll probably be some economic elements. And so for the community as a whole, supporting this through BIC or through the Alliance economically and otherwise, but it's not just economic. The design of the education, recognizing that there are limitations for the medical provider audience, is probably best done in a 2-hour format where didactic material is given for about an hour and a half and patient expression of their experience for the other half hour. That's a model that we deployed in actually larger time frames at the International Benzodiazepine Symposium. The expression by patients, the individual experiences, probably much more important than anything I said about the geeked out literature that I love to geek out on. But we want individuals that are comfortable to be available to speak to their individual experience, because that speaking to the individual experience probably turn more people around than the evidence-based literature. So I think that this leads to two types of studies. One is sort of the numerical, quantitative, 57% of individuals had hyperacusis, the sensitivity to sound, or whatever that number is. And then the other is a narrative study. And there was a beautiful study in the pain domain that was done in relation to the narrative experiences of individuals that had success and poor success with opioids, or absence of success, rather, with opioids. And it walks through the kind of narrative experience and kind of collects the sort of trend lines in terms of experience. That's the kind of narrative experience that I think is really important. That's evidence too, but not what we traditionally think of as evidence-based medicine. But it's the experiential aspect of all of this and how that, what are the trends in relation to those kind of experiences, and what can inform us, because that informs then what we next do in terms of evidence-based research in that regard. Because my perception is that in my practice and many others, probably, people drifted away because I wasn't listening, that I was discounting. And if indeed that is the case, which we can find through the narrative experience of individuals, that informs the evidence-based research in terms of what can we do as medical providers to be a better recipient of that kind of information without discounting those experiences and coming to solutions that work for patients.
That's good. Thank you. I want to ask one final question, and that is for the patient who's just found out they're dependent, read some horror stories, unfortunately, on the internet, is scared to death of what's going on, has already faced some tolerance withdrawals, is looking for medical support. What's your advice? What do you tell this person? Where do you direct them? What would you tell that person to do?
Take a deep breath and take a pause.
Okay.
Take care of yourself. Form your supportive network and plan before you do any actions, and plan with a medical provider that you have interviewed and is primarily a good listener. Better yet, has some benzo-wise type of knowledge that is going to be helpful, but primarily is a listener and is willing to pull out the Ashton Manual and other resources and regard what you and others have said about that experience as being valid. And then proceed slowly. Recognize that for the majority of such individuals, you've been on these medications for years.
Yeah.
Whether you stop or start to taper off this week versus next month is going to be inconsequential. I know there's a sense of desperation that got to get rid of these right away. Well, that probably won't make a difference. It's the ultimate success that's going to be important, not rapid attempts at success that can result in failure. Rapid reductions, if you push your prescriber too hard, they're going to say, "Oh gosh, I got to move this down 10% per week," and that can be a horrible mistake for the issues that we already mentioned.
Yeah, I was actually told by my provider I had to wait 6 months before I started my taper, which was extremely frustrating at the time. And I look back on it, I realized he was brilliant because I was not in an emotional mindset to handle the taper at that point. He told me, go get some tools, build your tool chest, and learn how to manage your anxiety, and then we'll talk on the taper.
Well, that's correct. So, I mean, there are tools that you can kind of build up around this,
Yeah.
but yeah, preparation is really important rather than speed into a tapering process.
Okay. Well, that's great. I just want to thank you for coming into the studio, talking with us today. I hope you'll do it again with us shortly.
Well, I'd love to, but I want to mention one more thing, and that is I want to apologize. We weren't listening, and we need to change the trajectory on that. And you've been extraordinarily patient with those of us that have taken a while to come around to this process, and I honor and respect, and I'm so sorry about all that, and sorry that it needs to continue in order for it to be successful over the long term. But it will happen this time, as opposed to previous attempts. 1979 with Kennedy, the main study group, a lot of efforts that kind of withered on the vine. This can't happen this time. This has to have durability, and so it's important for you to support your benzodiazepine survivor community, but it's also important, I think, to support the communities of individuals who are trying to change prescribing behavior as a mechanism to move this along. And as horrible as it may seem, patience is going to be required in that whole process. And Rumi, great poet.
I like Rumi, yes.
Yeah, had to be an alcoholic.
I think you might be right.
Because he said these words: "The wine we really drink is our own blood. Our bodies ferment in these barrels. We'd give up everything for a sip of this. We'd give up our minds for a glass. Soul drunk, mind ruined, these two sit helpless in a wrecked wagon. Neither knows how to fix it. And my heart is more like a donkey mired in mud, struggling and sinking deeper." That's the experience of addiction, but it's also the experience of individuals that are trying to move away from benzodiazepines, and we need to respect that as medical providers and recognize that we need to be in this game together to work through a solution. I appreciate your patience with us. I hope to encourage the patience among the medical providers and the listening experience that we would like to see them involved with going forward.
Thank you so much for being in the studio today.
Thank you, Dee.
Yeah, I appreciate it, Steve. And
I really do too.
So we'll talk to you soon, and we'll touch base later.
Okay.
Okay, thanks.
Thanks.
Oh, thank you. Thanks to Dr. Wright. As I mentioned earlier, when I speak with Stephen Wright, the time just flies by. What a great addition this two-part conversation has been to the Benzo Free podcast. My sincerest thanks goes out, and I hope to have the opportunity to work together again. I truly do. Now let's take just 30 seconds for a disclaimer. This podcast is for informational purposes only and should not be considered medical advice in any way. The host of this podcast is not a medical professional, nor is he engaged in rendering medical, health, or psychological advice, nor any other kind of personal or professional services. The views and opinions expressed by our listeners and interview guests on this podcast, whether read from textual submissions or presented in their own voice, do not necessarily reflect those of the Benzo Free podcast or of its host. Withdrawal, tapering, or any other change in dosage of benzodiazepines, non-benzodiazepines, or any other prescription drug should only be done under the direct supervision of a licensed physician. Our full disclaimer can be viewed on our website at benzofree.org/disclaimer. I'm not sure if there will be a podcast episode next week after we doubled up here, but I'll let you know. Until we talk again, please keep calm, taper slowly, and take care of yourself.